Hello everyone, welcome to Patho Excellence. In this lymph node cytology video series, till date we have discussed algorithm 3 in detail, including polymorphous and monotonous, small, medium and large cell pattern. Now in today's topic we are going to discuss, this is the last pattern, pleomorphic cell pattern, in which we are going to discuss Hodgkin's lymphoma, anaplastic large cell lymphoma in detail. So first of all, what is the definition of pleomorphic cell pattern? So whenever there is presence of large pleomorphic bizarre or anaplastic cells within a background of lymphoid cells, we will include it in a pleomorphic cell pattern. These atypical cells typically measure 40 to 60 micrometer or up to 100 micrometer, and it exhibits marked nuclear abnormalities including irregular nuclear contour, nuclear folding and indentation, multinucleation, polylobation, prominent nucleoli which is called macronucleoli, and hyperchromasia or vesicular chromatin, increased mitotic activity. So these features raise the possibility of high-grade lymphoid or non-lymphoid malignancy. So what is the cytological characteristic feature of neoplastic cell? It includes pleomorphism, anaplasia, binucleation, multinucleation, prominent eosinophilic nuclei which is important feature, abundant cytoplasm, apoptosis and mitosis, and background is very important where variable admixture of small lymphocytes, eosinophils, neutrophils, plasma cells, histiocytes, necrosis may be present. Now, what is the diagnostic importance of this pattern? It is a broad spectrum disease ranging from lymphomas to metastatic malignancy, and this diagnosis cannot be established solely on the presence of pleomorphic cells. So, what we require, one important thing is cytomorphology. We require clinical correlation, immunophenotyping, flow cytometry and molecular studies when required. Now, in this category, this is the list of entities which shows pleomorphic cell pattern. So, here one is Hodgkin's lymphoma, very common, anaplastic large cell lymphoma, and Hodgkin type richer transformation of SLL, CLL. Another category is diffuse large B cell lymphoma variants, thymoma, metastatic carcinoma, melanoma, or mesenchymal malignancies. Now, first of all, let's discuss Hodgkin's lymphoma in detail. So, it is a malignant lymphoid neoplasm characterized by few neoplastic cells, abundant reactive inflammatory background, characteristic RS cells or Reed-Sternberg cells, which is having unique clinical behavior, excellent response to therapy, and it accounts for 10 to 30% of lymphomas approximately. Now, what are the cells of origin here? The germinal center or post-germinal center B cells are the cell of origin. Now, according to current classification, it is divided into classic Hodgkin's lymphoma, which is of 95% cases. So, here classic Hodgkin's lymphoma is divided into nodular sclerosis type, mixed cellularity type, lymphocytic rich and lymphocyte depleted classic Hodgkin's lymphoma. Another category is nodular lymphocyte predominant B cell lymphoma. Formerly, it is known as nodular lymphocytic predominant Hodgkin's lymphoma, but it is biologically distinct from classic Hodgkin's lymphoma. Now, cell of origin, if we see, classic Hodgkin lymphoma, it is B cell origin, but it loses CD20, CD79A, CD19, 22, but it retains weak PAX5, and its NLPBL retain mature B cell phenotype. So, this is RS cells, and in which background we can identify eosinophil, neutrophil, mast cell, plasma cell, and fibroblast. There is Epstein-Barr virus association with classic HCL in approximately 40% cases and more commonly in mixed cellularity type than lymphocytic depleted type. And NLPBL, it is EBV negative, and this EBV virus we can detect by this EBR-ish technique and LMP1 IHC technique. Now, what are the clinical features? How patient presents to us? One, if we see age distribution, it is bimodal. Peak 1 is 15 to 35 years age and peak 2 is 55 years. And common sites are cervical lymph nodes, then mediastinum and axillary nodes. And characteristic is it is having contiguous nodal spread. Now, patient present with B symptoms which include fever, night sweats, weight loss, and other symptoms include pruritus, anorexia, and alcohol-induced lymph node pain. There is an Arbor staging. Clinically, we can divide stage 1 where single node is nodal region is involved, stage 2 where multiple nodal groups of same side diaphragm, stage 3 both side of diaphragm, and stage 4 where disseminated extranodal disease is there. And A, if these all stages if associated with constitutional symptoms, then it is called B, and if it is without any symptoms, no B symptoms, then it is called A group. So this is a detailed description of this stage, an Arbor staging system. Now, according to WHO 2022 update, the Hodgkin Reed-Sternberg cells, which is called HRS cells, rather than listing Hodgkin cells and Reed-Sternberg cells separately. So now onwards, we are calling it as a HRS cells, and these both cells, Hodgkin's and Reed-Sternberg cells, both represent the neoplastic cell spectrum of classic Hodgkin lymphoma. So now what is Reed-Sternberg cell? How will you identify in cytology smear? So here the hallmark is it is having large size, 40 to 60 micron in size. So you can compare. See, this is the RBC. It is having 7 micron size, and this is having larger or up to 100 micrometer can be seen. Features include binucleation, sometimes multinucleation may be seen, and prominent eosinophilic nucleoli, abundant cytoplasm, and it is having owl eye appearance. So here again you can see this is a diff quick stain where we can find RS cells having prominent nucleoli and reticulated chromatin pattern. See, this is again an pap stain. We can identify RS cell. There are variants of this HRS cell. So one is mononuclear variant, or it is called Hodgkin cell. These cells may have nucleus either bilobed or binucleated or multinucleated. This is the mononuclear variant, and it is having a reticular chromatin pattern. Large inclusion like macronucleoli is present, may reach up to diameter of up to 7 micron. So we can compare it with the RBC size of this nucleoli. If we see cytoplasm, it is abundant, pale, and vacuolated. So this is the characteristic of mononuclear variant of Reed-Sternberg cell, or it is called Hodgkin cell. Now, these HRS cells are frequently found at the edges of the smear. So whenever we screen the smear of cytology, Do not forget to see the edges of smear, and sometimes cytoplasm of HRS cells, because it is very fragile, may be lost during smearing or during the preparation of cytospin. So there will be large naked nuclei with prominent nucleoli. So we have to see for nucleoli. This is the histo section where we can find HRS cells like this, having owl eye appearance, oval nuclei, binucleation, prominent eosinophilic nucleoli, and this is the mono nuclear variant of this HRS cell. And in classic HL, we will find in background like small lymphocytes. Here you can identify small lymphocytes, eosinophils, plasma cells sometimes, and mast cell having bluish granules, histiocytes, and neutrophil. So, diagnostic clue is the presence of RS cells in this inflammatory milieu, and this RS cell represent 1 to 5% of cells in the smear, with mononuclear variants predominantly over classic RS cells. Now, what are the different variants of HRS cell? One, we have seen classic RS cells, mononuclear Hodgkin cells. Then mummified lacunar cell or LP cell. We will discuss in detail in next section. Now, another category is suppurative Hodgkin's lymphoma. So, in this category, there is predominantly neutrophils in background, and there are multinucleated or binucleated Rich-Sternberg cells in smear. So, this is called suppurative Hodgkin's lymphoma. It can mimic abscess or acute suppurative lymphadenitis. So, we have to carefully search RS cells to diagnose this suppurative Hodgkin's lymphoma. Now, these are the variant cells. One is mummified cells, or it is also called zombie cells, which is nothing but the apoptotic RS cells. So, here you can identify pink and bluish or eosinophilic and basophilic pycnotic nuclei and loss of cytoplasm, and more common in nodular sclerosis subtype. Second is popcorn cells, where it is having multilobated nuclei, folded nuclei, and having delicate nucleoli and resemble popcorn like appearance. And these cells are less conspicuous than RS cells, and here these are different variants, like one is classic multinucleated uh, uh, cell RS cells. This is classic owl's eye binucleated RS cells. This is mononucleated Hodgkin cell, and this is lacunar cell, where you can identify clear space around the nucleus, and this is pseudosarcomatous, where having enlarged elongated nucleus and cytoplasm. So, these variants having significance, how to differentiate all these HR cells in different categories. So, this is the table where you can see these popcorn cells are common in nodular lymphocytic predominant B cell lymphoma. Hodgkin cells in all classic Hodgkin's lymphoma subtypes you can identify. Lacunar cells, which is nothing but the cytoplasmic retraction with clear perinuclear space, which is called lacuna formation, which is due to fixation artifact and common in nodular sclerosis type. Mummified stage in advanced cell in advanced stage of classic Hodgkin's lymphoma, and pleomorphic cell is most commonly in the mixed cellularity pattern and advanced disease. Now, let's see different subtypes of Hodgkin's lymphoma in detail. So first is most common type is nodular sclerosis. As the name suggests, this pattern will show collagen band and most common in young adult, and mediastinal and cervical lymph nodes are commonly involved. It is having characteristic lacunar cell type. These lacuna are due to fixation artifact and it is visible in histopathology section. So, it is difficult to identify in cytology smears. Here the smears are having hypocellular in appearance. There is fibrosis, smaller nucleoli and more abundant cytoplasm. Another is a type of HRSL is syncytial variant. So, we can find here sheets of this cohesive HRS cell producing syncytial pattern. It can mimic metastatic carcinoma or anaplastic large cell B cell lymphoma. Second category is mixed cellularity, where in background you will identify all the eosinophil, neutrophil, histiocytes and granulomas sometimes. So, here classic RS cells are common and having mixed cellularity appearance. It is having strongly association with Epstein-Barr virus, and because of less fibrosis, we can identify numerous classic RS cells. More common in middle-aged men and HIV positive patient and in developing countries. Now, as the name suggests, third category shows lymphocytic rich. So, background resembles reactive lymph node and few eosinophils or histiocytes are present. So, we have to differentiate it with the non-nodular lymphocytic predominant Hodgkin's or now B lymphoma. So, here immunohistochemistry is essential and it is common in older males. Now, fourth category, name suggests lymphocyte depleted. So, here the smear shows scant lymphocytes, numerous pleomorphic RS cells and fibrosis. It is rare but aggressive and having worse prognosis among all the subtypes. Seen in HIV positive patient, advanced disease and developing countries, and it can resemble anaplastic large cell lymphoma or diffuse B cell large B cell lymphoma. Now, if we see immunophenotyping characteristic of classical Hodgkin's lymphoma, then a typical profile shows CD30 and CD15 MUM1 positive, PEX5 is weak positive. Negative stain CD45 EMA and strong B cell markers are negative. So, this PEX5 is diagnostic and very useful because it is a nuclear B cell marker. So, even though this classic Hodgkin's lymphoma loses most B cell markers, PEX5 usually remain weakly positive. So, this is the a useful indicator. Now, if we see immunophenotype of NLPBL, so here 2079A6, OCT2 and BOB1 positive, EMA in 50% cases, and negative markers are CD15, 30 and it is having mature B cell phenotype. So, here CD30, 15 positive, here CD15 and 30 negative. So, this is the differentiating table where you can identify what are the key cytological features, what will you see in background and what is the immunohistochemistry. And this is again according to WHO 2022 classical Hodgkin's lymphoma subtypes we have discussed in detail. And here you can identify how you differentiate classic Hodgkin's lymphoma where HRS cell phenotype shows CD30 and 15 positivity, where lymphocytic rich will have a CD30 positivity but 15 may be positive or negative, while non-nodular lymphocytic predominant B cell lymphoma will have a CD30 and 15 negative. Now, nodular lymphocytic predominant Hodgkin's lymphoma has been renamed as NLPBL, so nodular lymphocyte predominant B cell lymphoma, because it is having B cell phenotype preserved. So this NLPBL or formerly NLPHL, we have to differentiate it with this variant pattern of THR-LBSCL and transformation to this diffuse large B cell pattern. So here the popcorn cells are seen, which is having multilobated, folded and cerebriform, and atypical large B cell appearance. Background shows lymphocytic rich background and PD1 positive, CD57 positive T cells, and there is follicular dendritic cell meshwork, and signature clue is popcorn cells. So if we want to remember what is NLPHL or NLPBL in one line, so it is a germinal center B cell neoplasm characterized by CD20 positive, PEX5 positive, OCT2, BOB1 positive popcorn cells, and there is absence of CD59-30 expression. Now, how to approach a polymorphic cell pattern? So first of all, first step is to determine whether atypical cells are few or numerous. Now second step, assess background. If eosinophils are seen, Hodgkin's lymphoma, mixed inflammatory cells, so either Hodgkin's lymphoma or ALCL or then anaplastic large B cell lymphoma, or monotonous lymphocytes if seen, Richer's transformation, necrosis if present, then nature killer or T cell lymphoma or metastasis. Now go for step 3. Look for characteristics, whether they are rich Sternberg cells, hallmark cells, Damon cells or epithelial clusters, and last step is apply immunohistochemistry. So now let's see ALCL and what is hallmark cell, what is Damon cells in detail. So for Hodgkin's lymphoma, these are the important points to remember. First is RS cells alone does not diagnose Hodgkin's lymphoma. Second, reactive background is essential to diagnose it. Eosinophils strongly favor Hodgkin's lymphoma. Granulomas can occur in Hodgkin's lymphoma. PEX5 weak positivity is important clue. NLPBL is CD20 positive and CD30 negative. Nodular sclerosis is commonest type. Mixed cellularity is most strongly associated with Epstein-Barr virus infection. Hodgkin lymphoma spreads contagiously, and Hodgkin's lymphoma is one of the most curable malignancy. So these are the important points related to Hodgkin's lymphoma. Now let's discuss another important diagnosis in pleomorphic cell pattern is anaplastic large cell lymphoma or ALCL. So characteristic cells in ALCL is hallmark cell, which is having horseshoe shaped nuclei or kidney shaped nuclei or prominent paranuclear off, and here they also having CD30 positivity, EMA positive and ALK positive or negative. Now it is a T cell neoplasm, strong CD30 expression, and by definition this ALCL is T cell lymphoma having large pleomorphic cells, CD30 strong expression, hallmark cell, ALK expression, and it accounts for around 20% of T cell lymphoma, 2% of adult NHL, 20 to 30% of childhood NHL. Now current classification shows there are three types. One is systemic ALCL, which is either positive ALK or negative ALK, primary cutaneous ALCL, or breast implant associated ALCL, which is a distinct WHO entity. Now, if we see pathogenesis, activated mature T lymphocyte is cell of origin, CD30 positivity, and there is common loss is CD3, and it retained frequently CD2, 4 and 5. Clinically, ALK positive ALCL present as a child or young adult patient, male predominance, advanced stage disease, and extranodal involvement is common. Sites most common are skin, bone, soft tissue, lung, liver, and prognosis is favorable. ALK negative, most common in older adults, less extranodal disease, more aggressive, and prognosis is worse than ALK positive ALCL, and it is slightly better than most PTCL NOS type. Now, breast implant associated ALCL. It is a distinct WHO entity associated with silicone implants, presentation, late peri-implant seroma or as a breast swelling or capsular mass, and it is usually ALK negative, and when it is localized it is having a prognosis, excellent prognosis. So cytologically it is characterized by highly cellular smears, pleomorphic large cells, numerous atypical cells, there is frequent mitosis and apoptotic bodies, and unlike Hodgkin's lymphoma, tumor cells are abundant. So what is hallmark cell? It is having like kidney shaped or horseshoe shaped nucleus, eccentric nucleus, abundant cytoplasm, and perinuclear half. So this is the most important cytology clue. Other tumor cells other than hallmark cells are donut cells, half donut cells, red cells, embryo cells, hand mirror cells, and RS cell-like cells. So marked pleomorphism is common, and in background you can find reactive lymphocytes, eosinophils, neutrophils, histiocytes, sometimes cell cannibalism, and erythrophagocytosis may be present. So this is you can identify hallmark cells which is having kidney shaped appearance or embryo like appearance. So these three A, D and J having hallmark appearance. This is small cell type. These are donut cells having centrally clearing, and this is half donut shape. This is called multilobated floret appearance. This is plasmacytoid appearance, and this is hand mirror appearance. And here you can say this is multinucleated cell with wreath-like arrangement of nuclei. So these are the different shapes of the cells you can identify in ALCL. So this is hallmark cell, and here you can identify ring shaped nucleus and coarse chromatin, and here again paranuclear uh, HOF, and this is a large anaplastic with irregular nuclear membrane and large irregular nucleolus. So these are typical appearance of hallmark cell. This is donut cell which is having complete ring nucleus. If it is half or not full ring, then it is called horseshoe nucleus or half donut cell. Red cell already we have seen, embryo cell or hand mirror cells may be present. So these are the atypical large cells with prominent nucleoli and hallmark cell appearance. So what are the morphologic variants of ALCL? One is common variant, which is most frequent. Second is lymphohistiocytic, where predominant histiocytes is there, and small cell variant, where small neoplastic cell predominant and can mimic lymphoblastic lymphoma or small round blue cell tumor. So IHC is important. CD30 positive strongly, and characteristic pattern is membranous plus Golgi staining. So positive markers along with CD30 are CD45, EMA, CD2, CD4 and CD5. CD3 is variable, but PEX5 and CD15 is negative. So it is useful to differentiate it from Hodgkin's lymphoma. So ALK immunostain will help to differentiate whether it is ALK positive or ALK negative ALCL. Here these are the bizarre cells which are positive, showing nuclear as well as cytoplasmic positivity, and membranous positivity is also there, and it is useful diagnostic marker. Cytogenetics most commonly is fusion ALK and NPM1, and it shows constitutive ALK activation and detected by FISH, RT-PCR or NGS. In differential diagnosis, classic Hodgkin's lymphoma, peripheral T-cell lymphoma, NOS type, DLBCL, metastatic carcinoma, melanoma are there. So IHC is essential. So important exam points of few ALCL, if you remember: hallmark cells, strong CD30 for positivity, translocation is to 5p23q35, NPA1 ALK fusion gene. Younger patients are commonly ALK positive, better prognosis than ALK negative, CD45 positive, EMA positive, but PEX5 is negative. So it is the main differential diagnosis, classic Hodgkin's lymphoma from ALCL. So this is the differentiating table to differentiate ALCL from classic Hodgkin's lymphoma. Now another category is Hodgkin's type richer transformation. So by definition, when transformation of SLL or CLL into Hodgkin's type lymphoma, it is rare, less than 1% of CLL SLL cases, and do not diagnose it as de novo Hodgkin's lymphoma. So correct diagnosis, when you find background of CLL and along with this classic RS cells, it is Hodgkin's type Richter syndrome. So what is the clinical clue? Patient will have a long standing CLL SLL, rapidly enlarging lymph node, nodes are more than 5 cm in size, extranodal disease, B symptoms, and sudden lactose dehydrogenase or LDH elevation. Morphology, we will find RS cells in the background of CLL SLL cells. Prognosis is poor and median survival is less than 1 year. So de novo Hodgkin's lymphoma versus Hodgkin type Richter, if we want to differentiate. So Richter syndrome will have RS cells in the background of CLL, clonally related and poor prognosis, while de novo Hodgkin's lymphoma will have a reactive cell background and non-clonally related and better prognosis. Now, another differential in pleomorphic cell pattern is DLBCL variant. So, it is primary mediastinal B cell lymphoma and T cell histolytic rich large B cell lymphoma. So these variants are having features that may resemble Hodgkin's lymphoma but usually lack true Hodgkin's or RS cells or HRS cells. So diagnosis is by flow cytometry and immunohistochemistry. Peripheral T cell lymphoma NOS type may show giant bizarre cells, pleomorphic cells. Diagnosis by immunophenotype and CD3 positive and T cell marker positive, but they do not have Reed-Sternberg cells. Natural killer or T cell lymphoma, it is having extranodal nasal type, cytologically intermediate to large atypical cells, pleomorphic cells may occur, and immunophenotype, if we see CD3 cytoplasmic positivity, CD56 positive, EBR positive, but 15 and 30 is negative. Extramedullary hematopoiesis, it is important diagnostic pitfall because megakaryocyte may mimic Reed-Sternberg cells and ALCL cells. So clue is presence of erythroid and myeloid precursors. So this mixed population of hematopoietic cells will help us to differentiate it from other categories. Thymoma, it is a mediastinal mass where large epithelial cells, prominent nucleoli and background of many mature lymphocytes. So it may mimic Hodgkin's lymphoma or ALCL, but cytokeratin is positive in this neoplastic epithelial cells. Metastatic carcinoma usually have a cluster, so cohesive clusters and large pleomorphic cells. Syncytial Hodgkin's lymphoma may mimic with this metastatic carcinoma and ALCL. So what are the example? Nasopharyngeal carcinoma, anaplastic thyroid carcinoma, lung carcinoma, urothelial carcinoma are having pleomorphic cell pattern, but here cytokeratin is positive. Now metastatic melanoma, this is a major cytologic mimic because it is having binucleated giant cells, sometimes multinucleated, prominent macronucleoli, which is this cells called Damon cells, and clue is sometimes you may find melanin pigment and intranuclear pseudo inclusions. So your positive markers are S100, SOX10, Melan A and HMB45 to differentiate it from other pleomorphic cell pattern. Metastatic sarcoma, if we see, uh, in sarcoma there is rare lymph node metastasis, but some undifferentiated pleomorphic sarcoma, rhabdomyosarcoma, neuroblastoma may be present. So here this is the case of high-grade undifferentiated sarcoma, which is malignant fibrous histiocytoma, which is metastatized to lymph node. And here you can identify bizarre large binucleated cells which may mimic Reed-Sternberg cells. So here useful markers in rhabdomyosarcoma, there is desmin and margenin. In case of neuroblastoma, NSC, synaptophysin and chromogranin. So diagnostic clue is neuropil in neuroblastoma, and this IHC is must to differentiate from other pattern. So this is the differential table where these are the entities where you can use these IHC marker to differentiate from each other. So this is the revision table. If classic Hodgkin's lymphoma, where clue is RS cells and eosinophils. Anaplastic large cell lymphoma, hallmark cells and perinuclear Hoff. Chronic lymphocytic leukemia, Richter transformation, RS cells in CLL background. Peripheral T cell lymphoma, you find pleomorphic T cells and extranodal natural killer or T cell lymphoma where necrosis and pleomorphic cells present, and metastatic melanoma shows Damon cells, thymoma where you find epithelial cells plus lymphocytes, and in carcinoma cohesive clusters of malignant cells are there. And here in all this category ISC marker are very much helpful to differentiate all these pleomorphic cell pattern categories. So I hope now you will whenever you find this pleomorphic cell pattern, you will easily distinguish classical Hodgkin's lymphoma, anaplastic large cell lymphoma, and metastatic carcinoma and metastatic melanoma on the basis of morphology, background population, and immunophenotype, which is essential for accurate diagnosis. So, this is the take home message, that whenever you see cytology smear, always look morphology of the malignant cells as well as background of the smears. So, now the next topic we are going to discuss infectious and non-infectious lymphadenitis. So keep watching, and if you haven't yet subscribed this channel, please like, share and subscribe this channel for more such important videos. Thank you.